Excellent. That was excellent. So, Dr. Evans, is there any indication in your practice for an ACL repair? And if there is, who, I guess, what's the anatomical problem? You know, when is that indicated, and what athlete is that indicated, if ever?
Yeah, I have not done much in the way of ACL repair. So there's, I think there's kind of two different kinds. So there's the avulsion. So I've had some patients that I've gone in operatively and kind of said, okay, we might just tie this down. So if it pulls just off of the femoral origin site rather than a mid-substance tear, then sometimes that responds to a repair. If it's a partial tear where one of the bundles gets torn, then you can tie that up with some sort of suture fixation. That will heal pretty nicely. As far as a mid-substance tear, there's some studies, especially kind of out of Harvard, about this ACL repair technique where they use a scaffold and fix that. That is not something I've done myself. It's got pretty good results at 2-year follow-up. So I mean, it's a relatively new technique, but it's promising, and that's kind of more in the pediatric population. Which is a enticing option if you don't have to, whether you use cadaver graft or take a tendon out of a 14-year-old or 12-year-old and you can reuse their own native ligament and just get it to heal itself. I think that's a really exciting option. Again, not something I have personal experience with, but it's in the works, I think.
That's excellent. We've done some ACL repairs, like you said, on avulsions using fiber tape. And anchors, swivel lock anchors, and there have been people that have reported some cases where they're going more to repair, and they've actually reported pretty good results. But most of them have been more of the avulsion variant, where the ligament itself has been pretty solid, and you weave the fiber tape through the stump of the ACL, and then with a swivel lock, basically re-impact it onto the lateral wall. And I don't know what the long-term results are going to be, but I think you're going to see more of that as the strength of the fixation improves. Describe for us complications. So you've done your ACL, you've used your quadriceps or whatever your graft of choice has been. Give us the pitfalls, give us the complications, and tell us after that how you fix those complications.
So some of the more rare ones, but I mean, we do see it occasionally, would be things like infection. So relatively uncommon, less than 1%, but it still happens that the graft can get infected. So usually that involves surgery to wash out the infection and try to do as much as you can to retain it, and antibiotics and things like that. You can get what we call arthrofibrosis, or basically stiffness in the knee. So especially if you are really eager and you're trying to get these patients in very early after their injury, that can be a problem. So a lot of times I will give patients a couple of weeks to calm down and let the swelling and everything go down, and they can start some prehab stuff like Amanda talked about, and that can be very helpful for their recovery. But if you operate too soon, then they can get stiff. Some patients just form a lot of scar, and they can get stiff as well. I think soberingly, I think a lot of the complications have to do with what you and I do and where we put the grafts in and how we position the tunnels. So I think there's been a lot of emphasis and a lot of work on the appropriate places to put the grafts, and there's some technical things about different tools and instruments we can use to put the grafts exactly where we want them, rather than being kind of confined by maybe where we started on the tibia, where it's going to end up in the femur, where a lot of patients before get very vertical tunnels and they might be stable for translation but have no rotational stability. Now through some different techniques we can do that. So and then we kind of talked about the re-rupture rates, and so sometimes that can be due to where we put the graft, sometimes it can be due to the quality of their graft material. So if it's their own tendon or if it's cadaver tendon, we've already mentioned that some of those can re-tear, and that can be a challenging situation. But those I think are the main ones.
And when you talk about the re-rupture rate, kind of give us
Ballpark.
the percentage. The percentages that you would, so you see a patient, you see a 16-year-old male, he's torn his ACL playing high school football. What do you tell the parents in terms of what the percentage or what the chances are he's going to tear his graft, number one? And number two, what are the chances he's going to tear his other ACL? Because that's a common question asked.
Yeah, I think the studies are, you can you can quote a lot of different numbers from different studies. So I mean, I think with an autograft with their own tendon, it's about 2 to 5% is what I would tell patients. It's in the single digits. It's not that common. If I've got a patient that is an older patient, then that's going to go up a little bit. And actually, interestingly, younger patients, so females, bigger patients that have more valgus in their knee, a 14-year-old that tears her ACL is much more likely to re-tear it than a 18 or 19-year-old female. And so some of it kind of depends on those things. And then if it's an allograft for whatever reason, it's 3 to 4 times that. And the same thing on the other knee. I don't, again, I think there's a bunch of different studies. I think it kind of depends. So if it's a football player that got hit a certain way and his knee gave out, his chances are much lower than if it was a soccer player that's a 15-year-old female and she just planted her foot and went to pivot and her knee gave out. She's got some intrinsic factors, whether it's size of her ACL, whether it's the size of her notch, whether it's her neuromuscular control, all those kind of things. She is at a much higher risk of tearing the other side.
No, that's excellent. That's excellent. And in terms of return to, and you can pick your sport, football, volleyball, soccer, because that's the first question mom and dad are going to ask, or coach is going to ask. You just reconstructed the ACL, or right before you reconstructed the ACL. What are you going to tell the family, the coach, etc.? When can they go back to two kinds of sports, the non-contact sports and contact sports, and I want you to separate them. And how does that impact our re-tear rate?
Yeah, so I start by kind of telling them, look, this is a season injury, because that's a lot of the times what patients really want to know is, am I going to play again this year? So we used to tell folks 9 months to a year, and I think that's still probably true for kind of getting back to full participation. I mean, Adrian Peterson was about 9 months out. He's about as perfect of a athlete as there was when he tore his ACL, and it took him 9 months to get back to playing. And that was kind of unheard of at the time. I think some of the high school athletes I've had back sooner than that, not saying that they're better athletes than Adrian Peterson, but their level of demand on their knee is not as great as an NFL player, say. So I think for me, it's much more based on a functional progression. So we got to get their swelling down, we got to get their quadriceps strong, and then we got to get them back into sport-specific drills. And so I usually let them start doing sports between 3 to 6 months, kind of depends on what sport they're doing and what kind of activities. And then usually by about 6 months, I can let them go with non-contact sports and non-contact practice freely without any sort of restriction. And then I tend to get closer to 9 months before I'm letting them go back and play football and things like that. It all depends on the patient and their rehab. It's very individualized, but that's a rough timetable, I would say.
Thank you. And Amanda, talk to us about kind of the functional part of rehab. I mean, it's one thing to get their swelling down, get their range back, get their glute working, etc. So now the athlete comes in, maybe they're 4 or 5% within their contralateral knee, full extension, full flexion. What's next? What do we have to do to get that athlete back on the tennis court or back on a football field? Give us kind of the functional exercises or the functional rehab program that leads us back to sport.
So I took a note out of Dr. Evans' book from our last podcast, and I printed out a nice little picture. So this picture is going to show you what increases the stress on the ACL. So a lot of our exercises moving forward from where you're talking about, Dr. Lehman, is going to reduce the risk of this happening again. So if you take a look at this lovely picture, there's the great picture of the valgus and rotation on the knee. So we really need to work to reduce the athlete getting into that position. So we want to look at hip strength and how their knowledge of their body works. So going to that proprioception and that balance component. Can we get them to move their leg in a manner where it's going to become automatic, where they don't go into that position and put more stress on that ACL, both on their operated leg that has been corrected and on their non-operated leg too. They're coming to us for therapy. So let's prevent the tear of the other knee so that you guys aren't doing that operation again. So not only doing it for their operated knee, but for this knee as well. A lot of times we're going to have to focus on glute strength. Those glute max muscles and glute med muscles are almost always weak. And especially when you're talking about those young female athletes. Female athletes have a higher Q angle, which means they're from where their hips are to where their knees are, they come in and they make that valgus position just at rest, regardless of whether they're moving, cutting, accelerating, decelerating. We need to reduce that by getting those glutes to function a little bit more, realigning those knees, looking at, do we need inserts in their shoes, or are their ankles not strong enough and their ankles are collapsing? We have to correct all those other secondary issues that, once you guys correct the knee and we get the strength going, the range going, and their ACL is good, stable, healed in place, now we got to make sure it stays that way and correct those secondary issues that are going to increase that re-tear risk.
And so along those same lines, Amanda, what can we do? I mean, are there some programs to avoid index ACL tears? Is there some way to decrease the incidence of ACL tears if in fact being in a valgus rotated position is negative? How do we stop, maybe primarily women, but both men and women from having that happen to them when they're playing sports?
So I think a prehab type situation is a perfect example. If we can get in with some of these athletes, school programs, trainers, increase the education on the position of the knee and working on these different movements to reduce them getting into that position, it's an education component. And then can we screen them? Can we go ahead and do a screen and see, can we identify hip weakness, ankle weakness, and then can we address that before the issue even happens? And work on getting them on, an individualized program right from the get-go to prevent these things from happening.
That's excellent, and I agree. I think the neuroreceptive or proprioceptive programs have been very successful. I don't think you're going to stop 100% of ACL tears, but if you improve 25 or 30%, you've made a huge difference, especially if you're doing 400,000 ACLs a year. That's a lot of ACLs. So after this reconstruction, we did this great surgery. We're patting ourselves on the back while the athlete goes back to play. What happens to the knee afterwards? The athlete comes in 10 years later. Now they have a job. They're the manager of a physical therapy facility in South Carolina, and they're limping and their knees swelling. What happens to them post-surgical? And give us 10 years, 20 years. What's the natural history of this surgery?
So I think this again is maybe a little bit of a humbling area of things. So I think the thought of going into,
for all of us,
yeah, exactly, kind of fixing the ACL and things is, one of the things we thought initially was, hey, this is going to prevent long-term arthritis. This is going to prevent arthritic problems. And a lot of the studies have actually shown that maybe it doesn't really do that. I think things we can say for sure are presence of a meniscus injury at the time of your ACL tear is very prognostic of how your knee's going to do. So ACL that tears, no meniscus involvement, those do much better in the long term and from an arthritic standpoint than do those that have a meniscus. And those are meniscus tears that are both debrided and repaired. And even the knees that the ACL is intact can lead to a progression of arthritis. So if the ACL is deficient, so if the graft either doesn't heal or re-tears, those do slightly worse, but it's not the ACL torn knees that have been repaired and are functioning well have no arthritis. Unfortunately, that's just not true. So if patients bring that up, I tell them that the main purpose of this surgery now is to make your knee stable now, to prevent other injuries to your meniscus, to prevent injuries to your hip, your ankle, all those things that Amanda was just talking about that all kind of coincide. And it's still important. It definitely doesn't mean we shouldn't do it. There's still other reasons to fix the ACL, but But long term, I think there's some element to some of the damage has been done by the time we see them in the office and they've had their initial injury.
And what's the future hold? Is there anything on the horizon, ACL grafts that are synthetic, scaffolds? What can we expect to see, let's say in 10 years or 15 years, or are we going to be doing the same surgery we're doing today?
Yeah, so I mean, I think we kind of touched on one earlier with some of the pediatric patients with this ACL repair, where they're using some sort of a bioscaffold to create that. I think if we can get to the point where we are not taking tendons from the patient's own knee and we have something else that works just as well, then I think that would be great. So yeah, whether it's some sort of synthetic material, whether it's some sort of cadaver graft, or the preparation is better so they don't re-tear, and don't have any sort of like the immunorejection type of issues, those would all be kind of better than what we have now. I think it's almost kind of like a knee and hip replacement where things are pretty good. You know, it's 90 to 95% of everything you'd want it to be, but there's definitely room. And as you mentioned, I mean, it's 400,000 a year. It's not a rare problem. And so if we can get 5% of those patients that are going to have re-tears down to 0.5%, then that's a big number of people that we can help.
No, that's great. So after the ACL or during the ACL, is there any room or any indications in your practice for biologics, stem cell, bathe the graft in PRP, try to put PRP in the tunnels? Is there anything suggestive that a biologic will help either heal the bone tunnel or improve the biomechanics of the graft?
I think for me that's kind of reserved for a revision type of setting. So if we've done our standard ACL and that has failed, then I'm going to throw the kitchen sink at it the next time. And whether that's doing some sort of repair or reconstruction of the anterior lateral ligament, whether it's adding something like an internal brace where you've got extra suture fixation in addition to whatever tendon you're trying to heal, whether you're doing some sort of an injection therapy with PRP. We know that can help with some meniscus healing rates as well. So if it's a patient that maybe has ACL plus a meniscus tear, we know that the ACL tear actually helps the meniscus healing, but that still may be a situation where we might add a little bit of biologic support as well. I think a lot of the issues with that honestly comes down to cost. It's not covered by insurance most of the time. And so you start talking to patients and say, all right, this is going to be X amount of dollars. And they say, okay, great. Where are the studies that show how well it works? And you're like, there's not a lot out there. Just kind of trust us that it's going to. I think that's a hard sell, and rightfully so. We want to make sure that that's something that we know works before we start doing it for everybody. But in those situations that we've done it once and it hasn't worked for whatever reason, then adding extra things I think is a good idea.
And Amanda, give us a little, give us your thoughts on sports specific training. Athlete comes in, he's 9 months out, he's doing okay, quads are a little weak, but he's just having trouble getting up off the floor playing basketball. Comes in, he says, I don't have any ups, I don't have any first step, my speed's not very good. Dr. Evans sends him over because he says, look, he's just not where he needs to be. What does that athlete need to do to get that first step back or to get that 40 time back or to improve their vertical?
Absolutely. So like you said, we can take a look and see where those deficits still lie. Is it quad weakness? Is it gastric weakness? Is it glute weakness? Are they limited in hip extension, range of motion? But then just retraining those fast twitch muscles where, a lot of our rehab initially is going to be slow movement, slow, controlled. But we got to get them back to those high rate, high speed, acceleration, deceleration movements, getting those muscles to perform fastly and get those fast twitch muscles going. So reintroducing those movements gradually, but quickly, all at the same time. And training that they land appropriately and they take off appropriately, working to reduce that valgus and ultimately improving their confidence. At that point, that athlete that's, just doesn't have the ups yet, they're not confident in their knee yet. They don't trust it. They don't think that it's going to hold and support them and support their weight and stop their weight. So we got to get them over that psychological component of their injury too. So by reintroducing them to those sports specific activities, letting them know, hey, you can do this and you can do it safely, is a huge barrier to overcome. And then they get their ups back.
That's excellent. So I'm going to ask both you if there's anything we missed, anything we should add, pictures, charts, anything we need to add additionally. So Dr. Evans, give us your final thoughts and any additions you may have.
Yeah, so I mean, I think what Amanda hit on there at the end is actually really important, the psychological component. I think we know that in a lot of injuries in orthopedics, whether it's trauma related, whether it's joint replacement, whether it's return to sport. So I often kind of tell patients with their ACLs, look, we're going to make it stable, but you're not going to trust that knee for a little while. And sometimes it just takes a season, or a lot of times I tell them it's going to be your second year back that you're really going to notice it. And I mean, I noticed that in the kids that I treat, the high school athletes, the first year they're wearing a brace all the time. They're always adjusting it. They're coming over the sidelines every time they get a hit, that by the second year, there's no brace anymore, and they just trust their knee. So I think the psychological part is a huge component of it. So I try to start with that kind of early on, first visit. And then the second thing kind of is bracing. I think that can be a little bit of a controversial topic, but there's not really any studies that show that bracing does anything to decrease re-tear rates. And so I think that's something that either with therapists or with parents more often than anything, getting the patient confident that, hey, when we get this ACL in, yeah, we're not going to let you go back and play football in week 2, but it's stable. We put it in a good place, and your knee is going to get stronger. And once they get through that first couple of months and that graft is incorporated, their knee is good. So I don't brace my knees with like the big, large T-scope braces and things like that. I do give them a little bit of a smaller support, and it's more of a mental thing, I think, but I don't make them wear it 24/7. And to me, that helps the patient move along quickly, get back to this being their normal knee, not feel like they're as injured and beat down without any kind of consequences to it.
That's huge. Amanda, give us your closing thoughts here. What did we miss?
So when you were talking about the long-term results of ACL tears and reconstructions, I thought you were talking about me. And I'm like, oh, okay, so we're going to just talk about my personal story here. But you described me almost to a T. I had a major knee injury when I was 16 years old, had surgery on my 17th birthday. They repaired 2 of my 3 torn ligaments in my knee and my patellar tendon. And, to go to those long-term results of, what to expect post-op and 10 plus years down the road, I've noticed when I maintain good strength in my leg, I avoid those little micro traumas to my knee. So I don't end up walking into the clinic with a swollen knee and limping. But the moment that I let it be lax and let my strength kind of subside a little bit is the moment that even the smallest thing, you stand up and you just tweak it a little bit. And then it results in little micro traumas and increasing your incidence of arthritis down the road. So I think it's huge to let these patients know, this isn't one thing that when you get done and with your formal PT or even your informal PT that you can just let it go. You have to continue to maintain that strength in the leg to maintain the stability that you have around it to aid those ACLs or whatever else was repaired, that you keep that knee as healthy as you can for as long as you can, because there is already damage to it. But I agree with Dr. Evans. I'm not a huge fan of bracing. I think it inhibits the athlete more than what it actually helps. And then it lets them kind of use that as almost a crutch or a reminder that the knee is injured. When in reality, when we get done with them, that thing is as strong could be. And chances are it's stronger than the other knee because of all the strengthening and balance and proprioceptive work that they've done on that leg. So I agree. Let's get them out of braces. Let's get them as confident as we can, get them back to their sport, back to their life. And it's going to take that second year till they're comfortable with it and confident. But
I agree. So Dr. Evans, do you brace your ACLs post-op?
I don't. I put them in just like a regular little hinge knee brace, not a not an ACL specific brace, not a hip to ankle brace, just something, a standard brace with a little bit of a hinge on it. But like I said, it's more for mental relaxation, I guess, for the patient and the family than anything else. But I don't make them wear it all the time. I have them wear it when they're starting to do their sports. So whether that's the conditioning, things like that. And then once they get to the point that they're ready to return to sports, I leave it up to the patient. Some of them like that feeling of having it. Other patients feel like it inhibits them. But if they ask me, I tell them that it does. There's no long-term data that it decreases rupture risk, which is what they really want to know. If I don't wear this brace, am I going to tear this again? So.
No, that's exactly right. And I agree with that. I think the literature is pretty clear. You're not going to decrease a rupture of the graft or a primary rupture. Even the Anderson braces don't really do much for the ACL. They help the MCL some. So I completely agree. And I agree with the psychological aspects. I mean, we do a lot of proprioceptive training starting right away in our post-op, because, you know, at 7, 8 months, 9 months, the hardest thing is that athlete has to go do something that really wasn't such a good idea last time. And it's hard to get them over that hump. So, you know, kudos to you guys. Listen, thank you very much. Again, you guys are excellent, and we'll do this again. So you have a good night. Have a good Thanksgiving.